All right. Good afternoon, everybody. And again, thank you for joining us for today's webinar. It's on updates on infection control for the ambulatory providers. My name is Boris Vilgorin, and I'm with MICTAC, the Managed Care Technical Assistance Center, and I'm joined by my colleague from MICTAC, Tara Reed. I'm also happy to say that we're joined by our OMH colleagues who will be presenting today, and also we will have opportunity towards the end of the presentation to answer some of your questions. And so they'll be with us for that portion as well. But before we get started, some just housekeeping. One is to mention that this webinar is being recorded and will be posted and made available after the webinar. And as I've mentioned again, we are going to have some time at the end of the presentation to answer as many questions as possible. So I strongly encourage folks to use the chat option and chat those questions in even throughout the presentation as kind of questions might occur to you. And again, towards the end of that, we will collect those questions and try to get to as many of those questions as possible with our presenters answering them. So with that, I'm going to turn this over to Moira, who's going to do some of the welcome and introducing herself. Moira?
Great. Hello, thank you very much, Boris. Hello, my name is Moira Tashjian, and I'm the Associate Commissioner for Adult Services here at the Office of Mental Health. First, I want to thank you for joining today, and also thank you for all the time you have spent serving individuals in very unique ways during this pandemic. We really want to recognize also the challenges that you have been through both personally and professionally during this period of time. And again, on behalf of the Commissioner, thank you for everything that you're doing. This afternoon, we want to have a conversation with you about the cluster system and infection control updates that we've been working on. It is our hope that we will be able to continue having these dialogues with you in the coming weeks and months, and look forward to your questions at the end of the presentation. I'm going to turn it over now to Dr. Flavio Casoy, who's going to present us all with the updates on infectious control. Dr. Casoy?
All right, thank you. Thank you, Boris. Thank you, Tara, for the opportunity to present here at MICTAC. And Moira, thank you for your leadership at the agency and everything that you've done to help us through. But especially thank you to all of you who are running our ambulatory mental health system. You're so critical to the well-being and the lives of hundreds of thousands of New Yorkers, and you've been faced with an unprecedented crisis, and I'm so thankful for how you all have been able to keep the system going and keep people thriving despite all the difficulties. So we had this conversation back in late March. We presented on infection control and what was happening with COVID, and since then we've learned so much more about this infection, and there's been so many new developments that we wanted to give this update in a more formal way, but we're always available to answer questions and help problem solve issues that come up, both through the OMH field offices and also through the program offices at central office. So let's launch into this update. I know that a lot of this information is going to be repetitive for many of you, but I just wanted to lay some basic groundwork on what's been happening and the science and just have a foundation. If we don't get through all the questions at the end, we will work on addressing them afterwards. So the goal is to get the information out there as much as possible. All right, next slide. Okay, so what are the COVID-19 symptoms? So just a reminder to everyone, COVID-19 is a virus that starts off as a respiratory illness. Infections sort of symptoms of the infection can appear within 2 to 14 days. Most symptoms appear within 2 to 14 days of exposure and infection. It's hard to have symptoms first appear after 14 days of exposure or before the second day. So most symptoms appear in that window, and that's kind of reassuring because it gives us a good sense of when the exposure might have been and how long folks have to be in quarantine or isolation. If there's a fever, we're considering a fever to be 100 degrees Fahrenheit or greater. Oftentimes, folks have the subjective feelings of a fever, the malaise, the fatigue, the muscle achiness, and the chills. I think many of us have experienced the flu before. It's like that. There can also be respiratory symptoms, sore throat, cough, shortness of breath, and then in more serious situations, difficulty breathing or decreased of oxygenation of the blood. Less common symptoms include runny nose, headache, nausea or vomiting, diarrhea, and the famous and much discussed loss of taste or smell. Of course, there's other symptoms too, and they can manifest in other ways, but these are the more common ones. You don't have to have all the symptoms, and as we'll discuss later, you can also be infected, be infectious, and be asymptomatic. So we'll get into that. Next slide. Okay, so how does COVID-19 spread? So the primary way that COVID-19 spreads is through respiratory droplets. Those are the little spit drops that come out of your mouth or your nose when you sneeze or cough or yell or sing or laugh or talk or play the trumpet or whatnot. When people are in an enclosed, unventilated space, such as a closed car or a small office, these droplets that are coming out can become aerosolized, where you have kind of virus that's kind of free-floating in the air and sort of saturate that space. As I mentioned, an unknown percent of individuals who become sick with COVID-19 and who are able to spread the virus never show symptoms. So they can move around the world asymptomatic and infect others. That's why it's so important to universally apply infection control measures, because you may be sick and spreading the infection to others, or you may come into contact with someone who looks fine, but they might get you sick. The only way to be safe is for everyone to take the measures. And then another way that COVID spreads, but much less importantly than through the air, is that the virus can temporarily, quote unquote, survive on surfaces. So, for example, you sneeze into your mouth, your hand, you touch a doorknob, someone else comes through, opens that doorknob, and then scratches their mouth or their nose, and then they can become infected. So for this reason, we really, really promote hand hygiene and reminding everyone not to touch their face. And I realized in March that I spend most of the day touching my face, and it's been a real effort to not do that. But it's super important to sort of hold back on touching your face and always wash your hands to prevent the spread that way. Next slide. Okay, so the size of the droplet matters. So the smaller the droplet in which the virus survives, the more infectious the disease. So measles, for example, which is one of the most infectious diseases that's out there, gets spread in these teeny tiny droplets that aerosolize easily and can just saturate a space and travel far. Ebola, travels in much larger droplets, and when they come out of a person, they tend to fall to the ground because of gravity. Ebola is a very deadly disease, but much less infectious. COVID-19 is somewhere in between. The recommendation is for folks to keep 6 feet distance, or to prevent those bigger droplets from traveling from an infected person and landing on your mouth or your nose or your eyes. So this distancing is really important. Now, how big are we talking about these droplets? We're talking about microscopic. If everyone can look at your pinky finger, your pinky finger is about 1 centimeter wide. If you divide your pinky finger, the width of it, into 10,000 identical slices, that's a micron. A hair follicle, for example, is about 120, 130 microns in diameter. These larger droplets are about 10 microns in diameter. The really tiny ones that get aerosolized are smaller than 5 microns. That's 5 little slices of those 10,000 of your pinky. So these are teeny, teeny, tiny droplets, and they travel, and it's impossible to see, and they land on your nose or your mouth, and then that's how the infection gets transferred. So it's not just the drops that you can see, but it's also these teeny, tiny droplets that you cannot see. So that's what we're talking about. And the smaller the droplet, the further they travel. Next slide. Okay, so how do we prevent COVID? So the goal, right, is to keep as much barrier and distance from our airways and the world, right? The infection usually starts in the back of the throat. When we sneeze and we cough, it leaves and it goes out into the world through a sneeze or a cough or however. And the same thing, infectious droplets are out there in the world. We breathe them in. It hits the back of our throat, and the virus starts replicating in our cells. So the more that we can implement these prevention strategies, the slower the virus will spread. And one, that will preserve our hospital capacity, but also two, the slower the virus spreads, the safer we all are individually. So a population level sort of implementation of prevention strategies helps keep us safe at the individual level. So first and most importantly is wearing a mask, a thick cloth mask or a surgical mask that covers your mouth and your nose is really important. Why your mouth and your nose and not just your mouth? Well, if you look at this picture, the mouth and nose are connected at the back of the throat. It's the same cavity. They both go into the lungs. So if you just have a mask covering your mouth, it's as if you're not wearing a mask at all. Should you sneeze or should you cough, the air is going to come out in the same way. And if you breathe in one of those droplets, you're in as large a risk of becoming infected. So you need the mask to cover your nose and your mouth. You want that physical barrier that will stop those droplets from getting, into your passages. Again, the physical distancing, keeping apart from people will reduce the risk that you're going to walk through a cloud, someone just sneezed and breathe it in and get sick. You don't want to do that. Reducing the time that you're indoors with people or at least in an unventilated indoor space will help reduce the risk of that aerosolization where the air becomes saturated with these teeny, teeny, tiny droplets full of virus. So making sure that the window is cracked or the doors to the outside are open or that the windows of the car are sort of open or that you have good ventilation. So your HVAC system, if you can monitor and control that, the more ventilation that there is, the more exchange of air that's happening, the safer that everyone in that space will be. During the summer and spring and fall, of course, we encourage be outside, but during the winter, especially in North Country and in Western New York where it's cold and snowy, that's harder. So that's something to consider. Again, rigorous hand hygiene, not touching your face will keep you safer. And we strongly recommend for everyone on this call, for everyone that you know, for everyone that you treat, for everyone in your social media groups to get the flu vaccine. One, symptoms of flu and COVID can be quite similar. So it's if you get the flu and you think you have COVID, it's going to be very stressful, and you're going to seek treatment that might not be helpful. But also, having the flu puts you at risk for much worse outcomes of COVID. So if you get that flu vaccine, you're closing off a pathway for some serious complications. So I strongly urge everyone here to get the flu vaccine if you haven't yet. Everyone you know should get the flu vaccine, because what we don't want is the flu epidemic underneath or on top of the COVID pandemic. It'll make a huge difference in saving people's lives. Next slide, please. Okay, so in terms of infection control, on November 12th, the Office of Mental Health posted its new infection control manual on the website. Here's the link. These slides are going to go out to everyone. The content of these slides is a summary, it's a synthesis of what's in this manual. But this manual is much more comprehensive than what's in these slides, and we strongly encourage people to look at it, read it. If you have questions, ask questions. This will help keep you and your clients and your staff safe. Make sure that you're educating your clients and your staff about these interventions that we've discussed: distancing, the mask, the hand hygiene. The Department of Health has some really great posters that are linked from the manual, so you can sort of click on the link and find these posters that you can print out and post all over your facilities, or if you want, all over your home, to remind yourself to do these things that will keep you safer. Remind your kids. So these are great resources. They're available in multiple languages. So take a look at them. We recommend that you increase how often you disinfect frequently touched surfaces like tables and doorknobs, light switches, toilet handles, sinks. So because this will wipe up that virus that someone might have left on that surface that it might infect someone else. So increasing that disinfection will reduce that contact transmission that we talked about. Tell your clients and your staff to report symptoms as soon as they can, as soon as they experience them, and go into quarantine and go into isolation, because that will keep their friends and their colleagues and their coworkers and their peers and their loved ones safer. And that's what we want. We want to reduce the spread and keep people safe. So isolation and quarantine is a critical part of that. It's not punishment. It's keeping those that you like safe. And given the realities of the physical plants of your programs, implement changes that will promote physical distancing. So change the furniture around. Put tape on the ground. Do what you have to do to remind people to keep that distancing, because that will help keep people safe. And again, get the flu vaccine. I can't say it enough. Okay, next slide. Okay, so this is a complicated slide that I basically cut and paste directly from the manual. So there's lots of information about this in the manual. It's talking about staff and when can exposed or staff who've had a close exposure to someone who has known or suspected COVID-19, when can they keep working? So if you're having significant staffing shortages and you've exhausted other solutions in terms of staffing, and the staff member is essential for the operation of your program, and it's approved by the supervisor and your HR department, that staff can continue working. Not that they're sick themselves. They've been exposed to someone who's sick, provided that they don't have any symptoms, that they're checking their temperature twice a day, and their temperature is consistently below 100. That they always have to observe these strict precautions, mask, distancing, and so forth. And if they develop any symptoms, however minor, they gotta immediately go home. And the recommendation is that they get tested. So the recommendation is if you have staff who are exposed to someone who's sick, they can continue to work, provided that these criteria are met. If they are sick themselves or if they test positive, that's a different story. They got to go into isolation and quarantine. Okay, next slide. Okay, so as you all have heard in the news, New York has implemented a microcluster color-coded strategy. And you can go on this website, the New York Forward website, to see if your home address or your program address is in a particular microcluster. And these are changing, and they're based on sort of published metrics that you can look up for your particular geographic area. In order of decreasing severity, right? There's the red zone, which is an active cluster of cases, and there's widespread community transmission. The orange zone, where it's picking up, everyone should be in warning and be in heightened state of alert. And the yellow zone, where folks got to change their practices and make sure that they're not going to keep getting worse. Now, this is important because OMH has incorporated the New York State microcluster approach into determining when programs have to take enhanced precautions. We can go to the next slide. So all programs all the time have to implement infection control precautions, right? The distancing, the mask, the hand hygiene, the education, but certain programs need to implement enhanced precautions. These are the programs that are in red or orange zones, programs that have had a cluster of 2 or more cases in their clients or their staff. If the local health department or if the Office of Mental Health, says, this program risky, increased precaution level, go to enhanced precautions, then you got to implement even more, more precautions to make sure that your population is safe. And these should last for at least 2 weeks more than the conditions that led them to to go into enhanced precautions are no longer met. So if you have a cluster of 2 or more cases on December 2nd, go on enhanced precautions and stay there until December 16th to give yourself enough time to see if any new people will get sick because there's asymptomatic spreaders in the program, and this will help keep everyone safe. Okay, next slide. So just a reminder, tell your staff they all need to be wearing a mask covering their nose and their mouth the entire time while on their shift. The only exception is if they are alone in their own office. A mask is always required when interacting with clients. If your staff is sharing an office, they should be wearing a mask even if they're 6 feet apart. You want that barrier between the back of your sit-out and the world in the back of your sit-out. And that mask will help keep you and you safer from everyone and everyone safer from you in case you're an asymptomatic spreader. It's important to educate your staff about this. The Department of Health just put out guidance just this weekend that they're also recommending all healthcare workers and all mental health staff, all staff at all mental health programs are healthcare workers, to also wear a face shield when interacting with clients. We know that this is a heavy lift for programs, so the recommendation is out there. Something to think about if that's something you have access to. If you don't have access to sort of face shields, double down on the distancing, the mask wearing, the hand hygiene, and keeping those offices, as ventilated as possible, because that will keep people safe. If you have access to those facial shields, implement those too. But if you don't, you don't. And so just do everything else really well. Okay, next slide. Okay, let's talk a little bit about testing. So the gold standard testing are these diagnostic polymerase chain reaction, or PCR tests, and access to them, and how to get one can be found on the Department of Health website. These are very accurate, both for positive and negative results. And if you have a negative or if you have a positive, you can be pretty certain that that's correct. It's possible that, if you have a positive, you go into quarantine, and 14 days later you get the test again for whatever reason, you might still be positive because they're so accurate that even broken up little bits of virus RNA can be picked up, even when you're no longer sick or no longer infectious. Now, the problem with the PCR tests is that they take a long time because they have to be sent off to a lab to be analyzed by trained technicians. So sometimes they take a day to come back, sometimes they take a week to come back, and that can be very, very difficult for people who are waiting for an answer to figure out, if their kid can go back to school or they can go back to work or whatnot. So there's more and more of these rapid tests, often called rapid antigen tests, which instead of looking at the gut of the virus, the RNA, they look at a little bit of the surface of the virus. Now, these tests are less accurate, but the results come back faster, so it's easier to act on them. So if someone has symptoms and they want to know if it's COVID, they have the test. The results come back, maybe within the hour at their doctor's office, and the test comes back positive. They got to go and they got to take precautions. We recommend that positive rapid tests get confirmed with a PCR test because that's the gold standard. But if you have a community that has a lot of spread, for example, not going to say anywhere in New York, but let me say a place in New Jersey, Newark, right, has a lot of spread, and you give a large population a lot of these rapid tests and they come back negative, that's reassuring, right? Because you can keep track of how fast this virus is spreading. Not as good as the PCR, but it gives you immediate information that allows you to make some decisions. So we can talk more about that if folks have questions. Okay, next slide. Okay, so let's talk specifically about outpatient programs and some of the things to consider. So generally speaking, whether you're on standard precautions or enhanced precautions, you want to educate your clients about COVID and the risks and how to stay safe. We've been in this for 8 months. Folks are tired. I'm tired. I'm a psychiatrist, and I've been thinking about infectious diseases for 8 months. This is difficult. But now is the time to double down on the precautions and push back against that COVID fatigue. So help your clients maintain vigilance, remind them, educate them. Super important. Incorporate this into your psychiatrist visits, your therapy visits, your, any visits that you have with clients. Make sure you're checking in about COVID. If you're seeing people in person, screen them ahead of time by phone if they have a phone available. Ask about COVID symptoms. Ask them to check their temperature if they have a thermometer at home, just to make sure that you're reducing the risk of transmission at your facility. If they're sick, but they still need to come in for an injection, well, then you can greet them with extra precautions. Double down on making sure that they have the mask, that your staff is ready and has the mask, and you can take them right away into the room where they're going to be getting the injection instead of having to wait in the waiting room or whatnot. So plan ahead and be ready and identify those who might be symptomatic. If someone comes without a mask, give them one. Make sure that anyone who comes through your doors have their nose and their mouth covered. Encourage the clients to wait outdoors, or create physical controls in your waiting rooms or bathrooms or elevators to prevent people being too close together, and to encourage and enforce distancing. That might mean taping off chairs, or that might mean moving furniture, or putting tape on the ground. There's lots of creative ways to do this, and every facility is going to be different because the physical plant is different. If possible, encourage clients to come unaccompanied. Of course, that's not possible for kids, and many adults need to have a companion to help them out. But if folks can come alone, they should come alone to reduce that density in the environment. Get rid of magazines, toys, and other frequent contact objects, because that's a way for the transmission, contamination and transmission spread, contact transmission. Protect your receptionist and other front door staff. A sneeze guard or a plexiglass shield will keep the droplets from hitting them, and keep them safe and keep them healthy. And conversely, in the terrible situations where your receptionist is an asymptomatic spreader, it'll reduce the risk of the receptionist infecting people who come by if they're behind a plexiglass shield. And if possible, we know that people rent spaces, and there's all sorts of different physical plants. Open the windows or prop the door open. It's better to have some cold, drafty air than aerosolization of this virus. If you have the windows open and there's some air circulation, the risk that the virus will become aerosolized falls quite significantly, and that will keep everyone safer. Okay, next slide. Okay, if your program is offering groups, so have no more than 10 people in the group, including the facilitator or facilitators. Try to have the group in a well-ventilated room where all participants can stay 6 feet apart. All participants should be wearing masks, covering their nose and their mouth. If the room does not fit 10 participants because it's not big enough, then you got to reduce the size of the group so that people can maintain physical distancing. And groups should not last more than an hour. And then in between groups, let the air circulate, let the air ventilate, so you don't have different groups breathing each other's air. And for individual sessions that are in person, both the client and the staff must wear masks for the individual sessions, and they should be sitting at least 6 feet apart. So it's you got to wear the masks and do the distancing. Okay, next slide. Okay, so we are encouraging the use of telehealth as much as possible, but some people do need to be seen in person, and it's the clinical determination of who can be seen by telehealth and who needs to be seen in person. Some people are going to will need to be seen in person all the time because that's what they need. Others can be purely virtual, and other folks who can have a combination of both tele and in person. And programs have to make a determination patient by patient, taking into consideration what the client wants as to who is appropriate for what mode. And programs have to maintain capacity to continue seeing people in person because some folks do need to be seen in person, but at the same time, as much as possible, reduce the density at their physical sites. For ACT teams or mobile crisis teams or forensic transition programs, any program really that are specifically designed to serve a more high-risk population that traditionally does not engage with outpatient services, assuming that your program is not currently in a red microcluster zone, aim to see these folks as much as possible in person, because we know that they are at high risk of falling out of care and of having all sorts of barriers to accessing technology, and we've seen some bad outcomes so far this year. when folks have tried to switch to virtual unsuccessfully. At the same time, you got to balance the risk because some of these folks have also pretty serious medical problems. So really make a clinical determination of what's the most appropriate approach to see these patients, and make it deliberate and make it person by person. Okay, next slide. So some considerations. First of all, think about infection control. Has the client recently traveled to a location on the travel advisory? Right. If so, maybe the scale shifts towards tele, especially if they're still in quarantine but they haven't gotten the test. So you got to follow the rules about quarantine. Does a client currently have COVID symptoms, or have they come into close contact with anyone with COVID symptoms? If so, that's an important consideration as to, what's the risk of their coming into your facility? What's your physical plan like? Can you maintain distancing? How many people can you have in the facility and still limit density? Right, that's an important consideration. What's your PPE supply like right now? Do you have enough masks for everyone? And if not, that's a really important consideration. Does the client have medical comorbidities that will put them at increased risk if they were to become sick with COVID? Or related, do they live with anyone with similar risk factors? So you might have a young, healthy client, but they live with a parent or someone with severe lung disease. So got to take that into consideration. Or how do they get to an in-person appointment? Do they have to take public transportation in a closed bus or a closed subway? What's the risk of that? And how does that get weighed against all the other risks? So things to consider. Next slide. Other factors to consider is an individual's cognitive or developmental capacity. Can they connect via technological platforms? Do they have access? Now, we've seen a huge digital divide. Do they own a phone? Do they have a data plan? Do they have broadband access? Do they have minutes? Is this feasible for people? Related, do they have access to public transportation? Are they able to get to an in-person visit? Can they establish a private space if they're going to be seen virtually? Something to consider is to have a discussion ahead of time with the client as to when tele or virtual is appropriate versus when you have to switch to in-person services. So everyone is in agreement and you have a frame. If you're seeing a child or adolescent, what's their ability to engage? Alone or with a caregiver? Does the caregiver have capacity to work the technology and engage with the care, or keep the child safe during these sessions? What are the different technology platforms that are available, and are they adequate to maintain rapport and communication with the client? Maybe what's available to your program is good for some individuals, but not for others. So thinking about that. And also, virtual care requires a little bit more of an active sort of role for the client than might be the case with in-person contact. So, what's the person's capacity to do that? Things to consider. Next slide. Other sort of clinical factors. Are there medical aspects of the care that require in-person visits? For example, do they need a physical exam like an Ames assessment? Do they need a long-acting injectable? Do they need to give a blood sample for laboratory exams? So if the case is yes, then they need to be seen in person. How strong is the relationship between the clinician and the client? How engaged are they? How important is this for the continuity of care? If the client is well connected, well established, that might be a different story than if the client is new. Assuming everything else is the same. Another consideration is do you have turnover in your staff? If someone is a new clinician to that particular client, maybe they need to be seen in person. What are the risks? Is there risk for suicide or other harming behavior, risk for violence, housing instability? Is there substance use? We've seen an increase in rates of opioid overdose in this pandemic. Are they coming out of jail or prison? Have they been going more frequently to the emergency room? Or has there been an inpatient admission recently? Now, these are important factors to consider on how stable the client is and whether they need to be seen virtually or in person. Can the person implement a safety plan remotely? That's a clinical determination that should be considered. As important is what's being done with the client. So some interventions, some evidence-based practices are very difficult to implement by telehealth. And if these are the approaches that the clinician wants to use, then it may be important to see the person in person. For example, there's some neuropsychological testing that is very difficult to implement virtually. Not all of it, but some of it. So depending what the clinician is doing, that's an important consideration. Next slide. So some systems factors. Are there transitions in care? Is the person changing programs or changing levels of care? Is there the risk of people falling into the cracks? If so, how does that impact the determination of tele versus in person? It may be that tele is better in these cases, for some people. In other situations, maybe that in-person warm connection is what's best. For folks who are coming out of prison, warm handoffs are recommended. These folks really struggle with safe transition to housing programs, access to their medications, accessing food and clothing, getting a telephone with minutes for telehealth appointments. This is a high-risk period where a lot of times folks, have bad outcomes. So that warm in-person contact as a transition is really important. And then what's the crisis response system like, when the person is remote? How do you get help to them if they're having a crisis? What's their support system? So these are important considerations. Next slide. Okay, so I've spoken about general programmatic precautions. I've spoken about when to think about telehealth versus in person. We encourage for anyone who it's appropriate for, to be seen by telehealth during the COVID crisis. But you got to do this careful deliberation as to who needs what type of care. Now, just to focus on the enhanced precautions, right? So for ambulatory programs that are taking enhanced precautions, don't do indoor groups. It's just not worth the risk of people breathing each other's air. So keep those closed until you go back to sort of less risky times in terms of not being in a red or an orange zone and not having sort of the local health department being worried about your program. If you are able to give your staff face shield or goggles, that's recommended. This is to, sort of lower that risk even more, that like a droplet will land in someone's eye and infect them that way. So if that's available, this is a good time to use it. Consider appointment blocks or maybe even whole days where you only see elderly or other high-risk individuals when you're seeing them in person. This will reduce the risk that these particular clients will come into exposure or contact with other clients who might have risky behaviors. So this will help keep folks safer. Okay, the next slide is our registration link for this Thursday. We're giving a similar talk for residential providers. This was a talk for ambulatory providers. So if you're interested in listening to, special precautions for residents residential programs, this is where to access that. We can open up the floor questions if you want to post your questions in the chat.
Yeah, excellent. Yeah, thank you, Dr. Kassoy, for this great presentation. Yes, as was mentioned, please feel free to chat in the questions. We did get a number of questions already, so just give us a second to regroup here. But while we do that, please, again, continue chatting those questions in. One thing, again, just to mention, as we did in the beginning, and I think in the middle of the presentation, this presentation is being recorded, and both the PowerPoint slides and the recording will be made available for all. So just I know we got a number of questions on that as well. So just jumping in with some of the questions we already got so far from our participants. So one individual was wondering if there is any studies that have shown, the kind of the distance the droplets travel, and if 6 feet is really just a best guess, or is there more information on that? And one of your slides talked about kind of the distance there.
6 feet is a best consensus guess. There have been studies. This is, you can imagine, this is who are you going to, exposed to? It's a very hard thing to study ethically. So Europe is recommending 2 meters. In the U.S., we settled on 6 feet. The CDC is recommending 6 feet. When these measures have been implemented, the transmission has gone down. Can I say that if there's a perfect type of draft, where is it possible for the droplets to be carried farther? Yes. That's why we say wear a mask, because it's not just 6 feet distancing, it's not just mask wearing. It's both. You want to keep that distance and put a physical barrier, and to help keep you safer. So it's a best but very, very, very good guess. That has some evidence behind it, but it's an impossible thing to study directly because you would never expose, unexposed people or healthy people to the virus just to figure this out.
Yeah, of course. Thank you for that answer. As you were just talking about also enhanced precautions, and one of the participants was wondering, just kind of as a definition within a program, when you have multiple programs for some hospitals or agencies, that have sometimes multiple programs in one physical location, like one building or even on one floor. For example, you can have pros and clinics or other ways. So when you're talking about enhanced precaution and kind of those 2 cases or kind of meeting that threshold, is this within a building? Is this within just, one program? Any guidance in that kind of definition?
Sure. If the location is in an orange or red zone, obviously both would be taking enhanced precautions, right? Or any program at that location should be taking enhanced precautions, canceling groups, and so forth. If you have a particular cluster, in a clinic or a pros program, I wonder, right, if there really isn't any interaction between the populations if they're located in the same space. I think that the issue is, right, be safe, right? If there's a risk of spreading the infection, do what you can to mitigate that risk. What you don't want is unidentified asymptomatic carriers walking around freely, right? So since we don't know who is infectious, when there's the possibility for concern, take that precaution. Like, do what you have to do to make sure that people aren't spreading this. So that'll be our guidance on that. So if staff talk to each other, staff can be friendly with each other in different programs. If you have one asymptomatic person from a pros program who's goes out to lunch with a buddy in the clinic, well, all of a sudden it's jumped from the pros program to the clinic. So it's important to just be careful with this. Hospital-based programs have the benefit of having infectious disease departments or really robust infection control programs. So take advantage of their guidance too. But if you're in a red or an orange zone, if you have a cluster, or if the local health department or OMH says be careful, then just be careful.
Yeah. Yeah, and also just, the other thing that I was just thinking about, some staff are shared among programs, right, especially in the same building. I remember when I was part of a PROS program, we sometimes with psychiatrists would work part-time in the clinic, part-time in PROS, and, kind of adding to your comment about, it might be spreading because it might be that psychiatrist who's the asymptomatic and we just don't know about it.
That's right. So
great. There's I guess some guidance a person's looking for if clients are refusing to wear a mask. Should a program basically tell the individual they can't see them in person, and I guess offer them telehealth services. Is that allowable? Is that okay? If an individual is refusing to wear a mask?
Well, I think you got to look at it clinically, right? I mean, there's a large part of the country that's refusing to wear masks. So I think you have to understand the behavior in the context of the client. If it's someone who might decompensate, you may want to sort of figure out a way to see them safely by making sure that everyone around them is wearing masks and you get them in the room right away and whatnot. But we really want to encourage people to wear masks. So, I guess the question is like, why don't they want to wear a mask? Do they believe that COVID is a hoax? A lot of people do. It's been highly politicized. It's very tricky. We don't want to not treat people, right? We don't want to sort of refuse to treat people who are enrolled with us. But this is very complicated. There's no great answer. But I would say use motivational interviewing and keep them safe. And if it's not someone who's at high risk, and if it's not someone, who is at risk of decompensating, you can tell them, well, we'll see you by telehealth. But if they are a higher risk person, then you gotta weigh the risks and the benefits.
Right. No, that makes sense. So talking a little bit about the orange zone, just to clarify, one of the participants, is just wants to clarify that they're under the impression that orange zones, or if the program is in the orange zone, that they should not be having any in-person groups. So just wanted to confirm that or clarify that.
Yeah, indoors. If you're able to have hardy participants who are still willing to do groups outdoors, that's okay. Just make sure that you keep the physical distancing and the masks. But we don't want people doing indoor groups if a program is in a red or an orange zone, until the program is no longer in a red or an orange zone. And I know that this is very complicated with scheduling and so forth, but really it's just having people sit together in a room is just not a good idea when there's community spread.
Got it. Yep. Thank you for that. Somebody is wondering if the eyeglasses could, substitute for goggles, for example.
Oh, I wish, but no.
No.
No, if you think about it, like when you go out wearing glasses in the rain, you can still have raindrops fall on your eyes. It just doesn't cover enough. If you're thinking of, if you think about it, like if you're like in a construction zone or whatnot, or if you're doing woodwork, whatever, your glasses aren't enough. You got to wear the goggles that cover more. The face shields are flimsy, but they do cover a bigger portion, and some of these so even non-medical goggles are okay to wear, like woodworking, or if you have to see someone who with a known COVID illness that they need to be seen in person, you could even wear ski goggles or swim goggles, while you're seeing that person. But no, eyeglasses aren't enough.
Got it. And so just in regards to your discussion about individuals that get exposed to someone who's positive, just for clarification, so the question is, when someone does get exposed to someone who's positive, if they, I guess, know quickly, should they actually wait a couple of days under some circumstance before they get tested, and then wait, of course, to make sure they're negative for that? Because, you talked about 2 to 14 days. So I guess the question is, somebody could potentially get tested too soon and have, false negative?
That's a great question. So wouldn't necessarily be a false negative. It'll just be that, that big Q-tip doesn't pick up any virus because there's not very much there. But, so the PCR test around day 4 or 5 after exposure is best. The rapid test is, also in like around day 3, 4, 5, 6, more or less. The rapid tests are better if you have symptoms than if you don't. But if you don't want to go get tested the next day, you want to give it a couple of days to wait and see if, just to give time for the virus to incubate if you've been exposed and you should become infected.
Got it. Thank you. Well, I think we're basically at time. We have a minute left, so I just want to say thank you, Dr. Kasai, for the presentation, and thank you, Moira, for this and other. I know we had other OMH staff that joined ready for some questions. And again, thank you, everybody, for joining today's presentation, and thank you for everything you do. I hope this was helpful and informative, and I just want to say, have a great rest of the day and good evening. Take care, everybody.
Thank you for everyone who joined.
Thank you.